Okay, let's get started. Good afternoon or good morning from wherever you are joining us. Thanks for attending our first session of the Institute for Pandemics Catalyst Seminar Series. Before we begin the actual seminar, I just want to acknowledge that this land on which the University of Toronto operates, and that is where the Institute for Pandemics is housed. For thousands of years, it has been the traditional land of the Huron-Wendat, the Seneca, and the Mississaugas of the Credit. Today, this meeting place is still the home to many Indigenous people from across Turtle Island, and we're grateful to have the opportunity to work on this land. And while the presentations today are not focused on Indigenous communities, we do acknowledge that the COVID-19 pandemic did have a more negative effect on Indigenous communities than some others. And so the focus of the Institute and the work that we do is to try and ensure that for future health emergencies and pandemics, there is a more equitable response to everyone that is affected by it. So today, like I said, is the first of our Catalyst Grant seminar series. Since 2023, IFP has provided over $1 million to research teams at the University of Toronto to support collaborative interdisciplinary research projects that tackle challenges in pandemic preparedness, response, and recovery. And so this seminar series is to highlight the work of those interdisciplinary teams. We will have sessions going on over the next 6 months, and each session is centered around a similar topic. So today, the two presenters or presentations are on long COVID. And before I introduce our presenters, a couple housekeeping items. If you do need the closed captions, there is a captions button at the bottom of the screen that you can click to turn on or off. They are AI generated, so they may not be the best, but they are available. If you have any questions for the presenters today, there is the Q&A feature at the bottom. Feel free to enter your questions at any time, but we'll get to questions after both presentations have finished. And we will have this recording and the presentation slides available after the webinar. We'll send that out to everybody who has registered and through our listserv and social media channels. So I would now like to introduce Kathi Wilson and Andrea Rishworth. Kathi Wilson is professor in the Department of Geography, Geomatics, and Environment at the University of Toronto Mississauga and the Graduate Department of Geography and Planning. Her research focuses on the health of newcomer populations with a specific focus on settlement, integration, determinants of health, and access to health and social services. Her research program is grounded in community-based research design, and she has extensive expertise in qualitative and quantitative research methods. Andrea Rishworth is an assistant professor in the Department of Geography, Geomatics, and the Environment at the University of Toronto Mississauga. Her work centers on the social, structural, and ecological production of health and well-being and the uneven impacts for people and places. And I will now stop sharing my screen and let Kathi and Andrea go on with their presentation.
Thank you. Thanks for the introduction, Ted. I'll just let Andrea get it set up. Awesome, thanks. So we're really pleased to be here, and obviously we're grateful for the support we've received from the Pandemics Institute to carry out the community-based research that we do. I'm just going to give a brief introduction that led us to our current project, which seeks to understand the impacts of structural racism on the immigrant and racialized population living with long COVID in the Peel region. And then I'll pass it on to Andrea, who is a co-lead with Professor Madeline Mant in the Department of Anthropology at UTM on the current project. So I'll just go to the next slide. So looking back at the COVID-19 pandemic, although immigrants and racialized groups bore a disproportionate burden of COVID-19 nationally, we know that the disease was unevenly experienced across the country and also within the province of Ontario. In Ontario, the Peel region, which is a large, sprawling region comprising the cities of Mississauga and Brampton and the town of Caledon, it was classified as one of Canada's major COVID-19 hotspots. Along with this, and contributing to this, is that the region is one of the most ethnically diverse regions in Canada. So immigrants comprise over 50% of the total population. Recent immigrants represent about almost 15% of the total population, and 65% of the population identify as a member of a visible minority group. And while the region represents about 3.7% of Canada's total population, it actually experienced almost 8% of all COVID positive cases in Canada, and 4.3% of hospitalizations. In addition, immigrants and racialized groups were 6 to 7 times more likely to test positive for COVID-19, and they were also overrepresented in COVID-19 hospitalizations and deaths during the pandemic. So our our first research project, so given what we were seeing in Peel region, an interdisciplinary group of faculty and researchers across the tri-campus at U of T partnered with Peel Public Health, Trillium Health Partners, and our amazing colleagues at the Institute for Better Health, and also the Newcomer Center of Peel to understand experiences of racialized immigrant and racialized non-immigrants living in Peel region during the pandemic. So as part of this work, we conducted, sorry, Andrea, I can't see that. Are you still sharing?
Yep.
Okay, sorry, it just disappeared on my end, but I'm going to keep going.
Oh, no.
So we conducted 100 interviews with immigrants and racialized populations to understand their lived experiences, socioeconomic and health impacts of the pandemic, and their perceptions of government responses. As part of that work, we found that over 3/4 of participants were working in essential industries like warehousing and manufacturing, where COVID exposure was quite high. Most reported lack of access to PPE or health and safety measures, despite being mandated by the government. Even when there were outbreaks in these industries, governments, obviously, they were allowed to stay open. Participants reported a lot of anger and hostility as they felt the government was prioritizing the economy over their health. And this was also compounded by the fact that Peel region received less vaccines per capita than their provincial counterparts, and most COVID testing, treatment, and vaccine centers were unevenly distributed in the region. And so overall, the interviews revealed that the economic, social, health, and healthcare impacts of the pandemic were exacerbated by structural inequalities and racial discrimination in the region. And this raised concerns from the participants about how one would live with and manage long COVID and access long COVID support and health services in a region already marked by structural inequalities. Sorry, I'm just gonna, you're on the next slide, right?
Yeah.
Sorry,
I'm
it's my
sorry you
computer.
can't
No,
see.
it's okay. So this brought us to the next project based on what participants were talking about, their concerns around long COVID. And so we know that while there are no consistent definitions of long COVID, it is generally recognized as a condition where COVID-19 symptoms persist or develop beyond 3 months of initial infection and cannot be explained by an alternative diagnosis. The challenge with long COVID is that the symptoms are highly variable. They change in intensity and frequency over time, and they can affect several bodily systems, ranging from respiratory, cardiovascular, neurological, gastrointestinal. Due to these, wide-ranging and inconsistent systems, there are no standardized tests or treatments for long COVID, with many individuals simply relying on self-management. So what we do know is that in 2023, approximately 18% of the Canadian population reported long COVID symptoms, but arguably it's thought that this is much higher due to variations in diagnostic criteria and barriers to access to care. We do know that long COVID has serious consequences for people's ability to maintain everyday life, with many reducing work hours or limiting their capacity to attend school. Current evidence suggests that women, older adults, and racialized and ethnic minorities are at a higher risk of long COVID, due in part to their higher rates of acute COVID-19 infection. And we'd also argue that these groups are at a higher risk of vulnerability due to long COVID, since they are overrepresented in jobs without sick leave or extended health benefits, are more likely to struggle financially if someone in the household is unable to work, and are more likely to experience barriers to access healthcare and to be misdiagnosed or dismissed. So what we don't know is there's really limited research, particularly for racialized and immigrant populations, with respect to what are the lived experiences of long COVID, how social and structural factors shape experiences of long COVID health and access to health and social care, and how experiences of long COVID vary within and between groups. And this is what we focused on for our pandemics Catalyst project.
So to begin addressing these gaps, we expanded this project to examine the lived experiences of long COVID among racialized immigrants and racialized non-immigrants living in the Peel region. So to do this, we created a community advisory board comprising individuals from the community who work in social care sectors and health sectors to provide input and oversight into the research objectives and research questions in order to ensure that the project was aligned with community needs. And so following this, we conducted 6 focus groups with 53 participants between November 2024 and May of 2025. And these focus groups were really looking at the health challenges, socioeconomic impacts of long COVID, as well as barriers to access health and social care services. And so participants for this study were recruited through a variety of different means. First, through our partner organization, the Newcomer Center of Peel. And we also developed a team of peer research assistants comprising individuals from the community who identify as members of the study population to help share the study information, build trust in the community level, and improve our understanding of the social context of Peel. And we also distributed this information through various social media outlets. So all participants in this study were 18 years of age and older, living in Peel at the time of the study, identified as racialized immigrants or racialized non-immigrants, and were either self-reporting long COVID symptoms or providing care for someone with long COVID. And prior to research, we received ethical approval from the University of Toronto. So all of the data here was thematically coded and analyzed using an iterative, inductive, deductive approach, and in vivo 12, which elicited main themes that I will present in a few moments here. So in terms of our participant characteristics, around 65% identified as an immigrant, just over half identified as women, and around 93% were personally managing long COVID symptoms. The majority were identified as South Asian. Around 65% fell between the ages of 30 and 50, and around 3/4 were working either full-time or part-time at the time of the study. So in terms of symptoms, participants indicated that they were experiencing a variety of different symptoms, ranging from flu and cold-like challenges, neurological and cognitive issues such as brain fog, numbness and nerve damage, along with hypertension and cardiac issues, fatigue and muscle pain, along with psychological issues such as anxiety and depression. So what I want to do here is highlight some of the main themes that emerged from the focus group discussions. And so first, although participants sought care for their health challenges, most providers, they indicated that most providers really took a uniform cookie cutter approach to providing services, which oftentimes meant pushing pills rather than digging deeper into their health challenges. So participants indicated that although they took time off from work and paid for transportation to seek healthcare, they felt like their concerns were oftentimes dismissed and neglected, which increased their feelings of anxiety and depression. With one person saying here, every patient has different symptoms, but doctors don't take you seriously. Symptoms are dismissed. It's a cookie cutter approach. They say take Tylenol and push you along, but it's harder to ask for help as racialized folk because there's a lot of other socioeconomic factors. So when you're taking time to ask for help, but you're dismissed, it creates anxiety and depression. Yet some participants indicated that although their questions were commonly left unanswered, they indicated and understood that doctors were were improperly trained to address long COVID, due in part to being overworked, underpaid, and really under-resourced. However, though, consistently being denied healthcare services left many to be reticent and avoid healthcare in the future due to the challenges of navigating the healthcare system and simply being denied. With one person saying here, many questions are unanswered. They don't have proper training for long COVID. They're overworked, so I try to avoid it because there's mental stress of navigating the healthcare system and just being denied. So a second theme focused on employment inequities and economic challenges associated with long COVID. And so almost all participants highlighted that although they wanted to take time off from work due to their health, they needed to go to work in order to get the money to survive. Yet when they were at work, however, participants highlighted experiencing stigma and doubt about their health challenges with coworkers, simply minimizing their realities, all of which increased their anxiety and feelings of suffering. With one person saying at work, there's stigma, like this person is taking too many days off, or you're taking advantage. Like people minimize your experience, or you're sick and you shouldn't be there. So there's stigma both ways. Likewise, participants highlighted how current employment structures were really incompatible with long COVID realities, since there were limited numbers of sick days, which meant that people were really forced to go to work or lose their job and create other unintended consequences. Yet when people were attempted to receive disability benefits, they were oftentimes forced to jump through bureaucratic hoops in order to receive really insufficient funding that was really unable to manage or cover their basic necessities in life, which was especially challenging for single parent households. With one person saying here, there's limited sick days. After that, you don't get paid. You're sick, but you need money, so there's financial stress and now inflation. This disease is creating employment, but disability is not enough. A third main issue and theme related to intersectional inequities. And so many participants who identified as women indicated that although they faced profound challenges in their daily lives, they were really unable to care for themselves due to competing demands and needs associated with financial and familial obligations, which oftentimes meant that they were neglecting themselves in dealing with these other things. With one woman saying here, being a female in the workplace, you're already marginalized as a single mother. I must work. I need the money. Even if I'm not well, I cannot take time off. So this adds to your mental stress and makes your health worse. Several women also indicated that although they wanted to take time off from work, due to their health, they were concerned about the progression and potential repercussions of being out of the workplace. With one saying here, you need to think about your progression. I feel like as a racialized brown woman, it's more the expectation I should be working or it's impacting my progression, but you're struggling just to live. And a fourth major theme related to political neglect and really government abdication of their responsibilities. So although participants really desired external support, they felt like the government had individualized responsibility for long COVID, with government at all levels really simply abdicating their responsibility to provide support, services, and education for individuals who are suffering with long COVID. With one person saying here, the onus is on the individual to get help. There's no community thing that can help you, but I think it's the responsibility of the government to take care of this thing, not the individual of the government. Likewise, participants felt like that despite the growing burden of long COVID in the communities, the government in recent years had been deprioritizing health, rather focusing on the economy and job creation, simply slashing healthcare resources and cuts, and really ignoring the long-term impacts of COVID that people continue to experience in communities. With one person saying here, we need resources from the government, but they're cutting the health budgets. It's like everyone is trying to move on too fast, but we're here feeling the long-term effects. So participants had a number of ideas about what should be done in order to better support them and their needs. So first was increasing education and awareness of long COVID impacts, both in the healthcare sector and at the societal level, given that there's really, it seemed from this research that there's a lack of acknowledgement that this continues to be an issue. Expanding pharmaceutical coverage for medication, given that many didn't have health insurance. Expanding paid sick leave and improving the Ontario disability benefits to cover more issues and take long COVID seriously. Also, developing and expanding government social and economic support for individuals and families who are managing long COVID, particularly for people living alone. Incentivize healthcare workers to specialize in long COVID research, as well as providing free, low barrier, community-centered mental health support, given the psychological challenges associated with living with long COVID. And so in terms of next steps, we'll be mobilizing this knowledge in a community event in the next month, which will be bringing together people with lived experience, researchers, community leaders, and policymakers in a deliberative dialogue to share the results of this research, collaborate together really in this groupthink process in order to co-produce knowledge on the challenges, needs, and concerns of living with long COVID, in order to develop contextually relevant, inclusive, equitable, anti-racist interventions with the aim of identifying future long COVID priorities in the Peel region. And so just to end, I'd like to thank our funders and our partner organizations, and thank you all for attending. And that is everything.
Great. Thank you both, Kathi and Andrea, for your, oh, my video's off. Bring that back on. Oh, gosh. Okay, well, my video, there we go. Yeah, thank you both for your presentation. And as I mentioned at the beginning, if anybody has questions, feel free to enter them into the Q&A feature, and we'll get to the questions after our next presentation. So I'm going to move on and introduce now Joseph Munn, who is a postdoctoral fellow affiliated with the Hospital for Sick Children, ICES, and the University of Toronto. He holds an MSc in kinesiology and a PhD in health and rehabilitation science from the University of Western Ontario. He specializes in population-based clinical research using health administrative data with a specific focus on respiratory disease. His interests broadly lie in making use of big data to improve medical decision-making and the delivery of care to Canadians. So Joseph, on to you.
Okay. The screen's sharing okay?
Yeah.
Okay, perfect. So as Ted said, my name is Joseph Munn. I'm a postdoctoral fellow at the Hospital for Sick Children, and this presentation is based on work that was recently published in BMC Health Services Research titled Investigating the Use of Diagnostics Codes for Post-COVID-19 Condition in Ontario Health Administrative Data. So long COVID, also known as post-COVID-19 condition or PCC, is defined as a patient continuing to experience symptoms 3 months after an acute COVID-19 infection, with symptoms lasting for a duration of at least 2 months. So in 2023, Statistics Canada estimated that 10 to 20% of adults who experienced the COVID-19 infection excuse me, would have long-term COVID-19 symptoms, with estimates as high as 25 and 38% for those who experience 2 and 3 or more acute infections, respectively. So based on these projections, it was estimated that between 13,000 and 26,000 people in Ontario would have acquired PCC in 2023. So in January 2023, in order to better understand PCC and to allow doctors to bill for it, the Ontario Ministry of Health introduced a new OHIP diagnostic code for PCC specifically. So the introduction of this code allows for physicians to bill PCC directly. This means that this code may represent a way to track and efficiently study PCC in Ontario. However, it's not clear how widely this code was being used or how useful it can be at the moment. So the purpose of this project was essentially to do the baseline work to start to understand how this new OHIP code is being used and if we can use it to track and study PCC in Ontario. So this project had 3 specific objectives. The first was to identify the prevalence amongst Ontarians overall and in marginalized and equity deserving groups to try and understand who is actually receiving a PCC code and if it is who we would expect to be receiving a code. The second was to identify healthcare utilization patterns for individuals who have received a PCC code and to try and understand how PCC affects patient healthcare use. And the third and final objective was to determine which physician specialties are using the code and if there are any specialties not issuing the code that we would expect to be diagnosing or treating PCC. So to do this, we conducted a population-based cohort study using health administrative data housed at ICS. For those not familiar, ICS is an independent nonprofit research institute that houses copies of Ontario's health administrative data, and it captures almost all of the publicly funded healthcare that's used in the province. So this includes information on physician claims, which allows us to capture outpatient visits. Then it also contains information on hospitalizations, the details of a hospitalization, including days in hospital and the reason for hospitalization, as well as emergency department visits. So it also contains a lot more information than that, but those were the areas that we were particularly focused on. So using this data, we captured every individual and physician who either received or issued a PCC code in Ontario between January 1st, 2023 and January 1st, 2024. So for this study, we collected patient demographics, which included age, sex, the geographic location in the province, which we split into Northern Ontario, Eastern Ontario, Central Ontario, and Southwestern Ontario. We also captured rurality, neighborhood income quintile, and immigrant status. We looked at comorbidities as well, and these included asthma, COPD, hypertension, diabetes, and congestive heart failure. And we also captured marginalization as defined by the Ontario Marginalization Index. So the Ontario Marginalization Index is a measure that's based on postal code. So it's a geographically defined measure, and it measures marginalization across 4 categories. So these include households and dwellings, which measures the types and density of residential accommodations, material resources, which assesses the ability to obtain and access basic material needs. So this dimension is heavily correlated with income quintile. Age and labor force participation, which includes information that describes the number of seniors and individuals not participating in the labor force. And then the racialized and newcomer population, which describes the density of new immigrants and self-identified visual minorities that are living in a community. So we also captured a number of PCC specific or COVID-19 specific variables, which included the number of PCC codes that a patient received, the number of previous positive PCR tests to see if they had previous confirmed acute infections of COVID-19, and the number of vaccinations that patients received pre-PCC. We also collected this baseline data for the rest of the entire population of Ontario so that we could understand how the PCC population differed from the rest of the population. So for every individual who received a PCC code, we captured all their healthcare use from January 2017 to January 2024. So this included all outpatient visits and diagnostic testings that they underwent, any emergency department visits, and hospitalization and days they spent in hospital. We also amalgamated all this information into a total healthcare use category, where we summed outpatient visits, emergency department visits, and days in hospital to create a single overall measure of the number of times a patient interacted with the healthcare system. So for example, if a patient had 1 outpatient visit, 1 ED visit, and 3 days in hospital, that would be 5 healthcare interactions, according to this total measure that we created. We then broke healthcare down by the reason for the visit to see why people were using the healthcare system. So, for example, respiratory disease, circulatory disease, musculoskeletal issues, and so on. So we calculated healthcare use for 3 different time periods. So the first time period was pre-pandemic, which was January 1st, 2017 to March 31st, 2020. The second time period was pre-PCC, so that was before the advent of the PCC code, which was defined as from the start of the pandemic to 24 weeks before a patient received their first PCC code. And the third time period was post-PCC code, so after the PCC code was introduced, which was from 24 weeks pre-receipt of the patient's first PCC code to January 21st or January 1st, 2024, which was the end of our follow-up period. So we use these three different timelines to establish a pre-pandemic baseline of healthcare use and a baseline of healthcare use during the pandemic, as we thought that the pandemic was likely to have an effect on how patients were using healthcare, and we wanted to understand how that might change between the three time periods. So we used a 24-week pre-PCC code time period because we considered it likely that healthcare use leading up to the receipt of a PCC code could be related to PCC itself, and we wanted to capture that information. So this time period was established based on a combination of clinical considerations and the disease definition. So technically a minimum of 3 months are required, but it can be longer than that if new symptoms develop between that 3-month period, as patients need to experience those symptoms for at least 2 months, and that could extend the time period during which you'd need to confirm a diagnosis of PCC. PCC is also a diagnosis of exclusion, so it requires that physicians rule out other illnesses, which could also extend the amount of time it takes for a patient to receive a PCC diagnosis, even though they're experiencing PCC symptoms all through that time period. So based on these factors, we thought this 24-week period or 6 months was probably reasonable in terms of identifying healthcare that could be related to a PCC code. So for physicians issuing the code, the only thing we captured was their specialty. So for the analysis, we calculated crude incidence by month and then plotted results. We calculated healthcare use for each time period and then the differences in mean healthcare use from pre-pandemic to post-PCC and pre-PCC to post-PCC to see how the PCC was affecting healthcare use. So weekly healthcare use in the 24 weeks leading up to and following the receipt of a PCC code was plotted. And to investigate how the PCC population compared to the rest of the population of Ontario, we created a PCC code received versus not received variable and captured that in the entire population of Ontario, and then used univariable logistic regression and logistic regression controlling for age and sex to calculate the effect of comorbidities, geographic location in the province, rurality, immigrant status, and marginalization on the odds of receiving a PCC code. So we found that 7,343 people received at least one PCC code in the province of Ontario between January 2023 and January 2024. The median age was 62 and 63% of the population was female. So patients received a median of one PCC code, had 2 positive PCR COVID-19 tests before they received their PCC code, and had a median of 3 COVID-19 vaccinations prior to receiving the code. When investigating the incidence by month, we saw peaks in February and November, with the lowest number of codes being seen in July. This anecdotally lines up with when we see largest number of respiratory infections, although didn't really understand why this was happening, as we'd expect a lag from respiratory infection to PCC code. So this is something we need to look into more. When we looked at the results of the logistic regression models to compare how individuals with PCC compared to the rest of the population of Ontario, we found that patients were more likely to be older, female, and from Northern Ontario. The Northern Ontario part was somewhat surprising because it's largely rural and remote, and we actually expected less healthcare access in that area. We also found that individuals with comorbidities, specifically asthma, congestive heart failure, COPD, hypertension, and diabetes, were all at increased risk of receiving a PCC code. And then when we looked at marginalization, we saw that those with the lowest levels of material deprivation, so those would be people with the greatest access to resources, actually had higher rates or higher odds of receiving a PCC code compared to those with the lower levels of marginalization. Higher levels of marginalization. So this means that people who have more access to material are more likely to get a PCC code. And then when we looked at the immigrant and racialized newcomer populations, we found that people who had the highest level of marginalization, so these are people who are living in neighborhoods with the greatest number of recent immigrants and greatest racial minorities, were less likely to receive a PCC code. Although this was only observed for the highest level of marginalization and not any of the other marginalization categories. So when comparing the three time periods, we found that the post-PCC time period had massively higher rates of healthcare utilization, with patients experiencing 86 more yearly healthcare interactions. So that would be the combination of outpatient visits, ED visits, and hospitalization than their pre-pandemic yearly rates. And then when examining the plot for healthcare use, like as you can see in the 24 weeks leading up to and following the receipt of a first PCC code, and so the vertical line in the middle there is when patients received their PCC code, you see a really big rise in healthcare. And then after they receive their PCC code, we see a rapid drop off following that. So when we broke down healthcare use by disease type, we found that there was the greatest use of healthcare for respiratory, circulatory, and abnormal clinical signs and symptoms. So abnormal clinical signs and symptoms includes unexplained symptoms from most other disease types, as well as things like general unexplained malaise or fatigue or fever and things like that. We also saw higher rates in infectious disease and mental behavioral health categories. So when examining the physicians that used the code, the family and internal medicine specialties used it most frequently, with a number of other specialties using it substantially less frequently, but these included respirology, pediatrics, geriatrics, critical care, medical oncology, hematology, physical medicine, infectious disease, and anesthesiology. The only specialty that we thought was notable that was missing was that there was no neurologists who had used the code in Ontario. So the number of people that we found, so the 7,343 individuals that were diagnosed with PCC was well below what the projected 13,000 to 26,000 expected cases. So we think that this means that the OHIP code is likely going to greatly underestimate the true burden of disease. However, the demographic and healthcare utilization patterns of the identified patients generally align with what we see in the existing literature, and that PCC more predominantly affects older, female, and comorbid patients. We also saw that most of the patients in this category had a confirmed history of COVID-19 infections, and that would have only included PCR tests. We wouldn't have seen anything to do with home tests or any PCR test that actually wasn't performed or funded by the province. And then when considering the extremely high levels of healthcare use, it suggests that this code might be only capturing or might be predominantly capturing very severe cases of PCC and not everyone in the population with PCC. It's also possible that given this is a fairly new code, all physicians in Ontario may not have been aware that it was newly introduced, and that may have limited its use as well. So when we looked at marginalization, the racialized and newcomer population and those with lower socioeconomic status were disproportionately affected by acute COVID-19 infections. And despite this, these groups were underrepresented in the PCC cohort. So there's a few possible explanations for this. The first is the exceptional immigrant effect, where immigrants tend to be younger and healthier when they move to Canada and tend to have lower healthcare use. This is potentially supported by the fact that we don't actually see huge racial disparities in the access to family care in Canada. But the other explanation that I think is probably more likely is that PCC is being underdiagnosed in these populations, as lower socioeconomic status and the racialized and immigrant populations may be experiencing more barriers to care, or their physicians may not be believing them. In the previous presentation, we just saw that they're often getting dismissed. So it feels more likely that these patients are experiencing barriers to care that are preventing them from receiving a PCC code or a PCC diagnosis. However, we're using geographically defined data, and we would need to get to a much more granular level to explore this in more detail and to better understand why these disparities are happening. So when examining the healthcare use, we saw that PCC diagnosis is associated with a sharp increase in healthcare use, which peaks around the diagnosis date and then rapidly drops off. So this pattern mirrors other chronic disease diagnosis trajectories. Specifically, it's fairly similar to what's seen with COPD. It's not entirely clear why this post-diagnosis drop-off happens, but it may reflect a transition from diagnostic healthcare use to a management-focused healthcare use, where patients are no longer using healthcare to try and establish a diagnosis and are now managing their symptoms. For example, patients may receive their diagnosis and then be able to develop a management plan with their physician instead of looking for an answer to why they're experiencing their symptoms and using a greater amount of healthcare. This kind of highlights why it's important for physicians to understand what PCC looks like and how to diagnose this. So we also don't know if this drop off in healthcare use is going to be sustained for an extended period of time, as we only had limited follow-up for most of these patients. So that's also something that's going to need to be looked at in the future. And then when it came to healthcare use types, they generally align with what we see in the literature with common symptom clusters, except we didn't see very many musculoskeletal issues, although we think that this may be that they were just being captured under the abnormal signs and symptoms categories, with diagnoses like fatigue or unsteadiness being classified there. So to conclude, the PCC diagnosis code at present likely cannot accurately monitor the full burden of PCC in Ontario. But despite these issues, it may be useful for studying PCC, as we think that the population that we captured by identifying everybody who received a PCC code, they looked like patients who should be getting PCC. So it may be useful to efficiently capture a large population to study PCC. But this work is very much preliminary and in the beginning to understand this code and the characteristics of patients who are receiving PCC in Ontario, and more work needs to be done to investigate PCC and the use of this code. So just like to thank the Institute for Pandemics for funding this work, and the team members on this project, Andrea Gershon, Peter Austin, Claire Atzema, Lee Fiddler, Zusong Wang, and Stacy Butler. Thank you very much.
Thank you, Joseph. If Kathi and Andrea would like to turn their cameras back on, we can move into the Q&A portion. So if you have questions, feel free to place them into the Q&A feature, and I will moderate the questions. I do have a question before I get to that, to connect both of your presentations. So I think it was either Kathi or Andrea mentioned it was 18% of your participants reported long COVID, which you thought was low. And Joseph noted that the actual PCC assignment was low in racialized and immigrant populations. So I'm curious if the reporting of low in your participation was based on them not being assigned that, or like where do you think that the low number comes from?
No, I think there was some confusion. We were just reporting on the 2023 data.
Okay.
Yeah, but I just wanted to say that, Joseph, that was just such a fascinating presentation. And at first, I think, Ted, we thought, oh, we were doing such different work, but they were so complementary in terms of the quantitative and the qualitative findings.
Right. Okay. I'm going to move into some of our questions here. There's a question for Andrea and Kathi, wondering if there was any distinct experiences connected to immigration status. For example, student, worker, PR, refugee, etc. And I think, Andrea, you wanted to answer that.
Yeah, I tried to type in the chat there, but yeah, it didn't work. And for this study, we didn't find anything particular with respect to immigration status. However, though, most of the participants were long-term immigrants, skilled immigrants who had come to Canada, and so we don't have like student individuals who came out on a student visa or temporary workers or refugees in this sample, so I can't totally speak to that. But with the first project, there definitely was variations with respect to immigration status in terms of their ability to access vaccines, healthcare, employment, and really heightened precarity during the initial waves of the COVID pandemic. But great question, and we're hoping to do more research and follow this up. But yeah.
Great, thank you. Next one, this one's for Joseph. It's, could the post-diagnosis drop-off be related to patients moving to private healthcare? Someone's friends who are living with long COVID are all accessing private clinics, including sports medicine clinics.
That's entirely possible. It would definitely explain why we're seeing a drop off, that people are maybe not getting the answers that they want in the public sphere, so they're moving to private. It would also make sense given that, to maybe put it a little pejoratively, COVID-19, long COVID is sometimes referred to as a rich people's disease, in that it's higher socioeconomic status people who get the diagnosis, and that mean they may have more resources to step outside of publicly funded healthcare. But we also see that drop off happen in other diseases as well. And it's partly because management plans are a big part of reducing healthcare use, and that patients aren't looking for an answer, and they don't need to use the same level of care to try and explain their symptoms.
All right. Next one's a kind of similar, I think, related questions. Lynn Johnson says they suspect that some patients with PCC might visit their physicians with non-PCC medical issues, such that PCC is not getting coded for, making admin databases less sensitive to determining rates. So would a Statistics Canada focused survey on PCC have some utility for obtaining a more accurate estimate of the impact of PCC?
Almost certainly it would. Part of the problem is it's a diagnosis of exclusion. There's really no gold standard for PCC. So trying to, I mean, we're basically like, I didn't say long COVID in the presentation, or people that were diagnosed with it but received a code very intentionally, because we don't know if they actually have long COVID, for one. And for two, it's very new. So it's sorry, I'm straying away from the question here a bit, but yes, we almost certainly would need a Statistics Canada survey that would help probably determine race more effectively than or help determine if the PCC code can be used more effectively. Sorry, I'm not sure I've answered your question there.
Okay. There's a question about how do you see your findings reflecting what is already known or emerging about patterns with other post-viral conditions? And I think it could be for both, or anybody wants to take that one.
I guess I can hop in first unless Kathy wants to go.
No, it's okay, Joseph.
So it's similar to what's seen for, I'm just going to speak to COPD because that's what I'm most familiar with, but it's similar to what you see in patients with COPD who get the flu, who tend to have elevated healthcare use for long periods of time after a flu infection. And so they tend to have long COVID-like symptoms after flu that can last 6 months to a year after infection. So I would say it's similar to what you see in other viral infections. And then I don't know if Kathy wants to add something there.
Yeah, I was going to add something from our first project. So, we tend to assume because of the healthy immigrant effect that, newcomer populations, are always shown to be healthier than the Canadian-born population, but certainly our quantitative analysis of COVID-19 data in Peel region just really disrupts that. What we know in that recent immigrants, Peel region and other places were much more likely to contract COVID-19. And I think it does raise questions about how well this, long-standing theory of recent immigrant health is going to pose, how well it's going to hold up for other infectious diseases.
Okay. There was a second question from that person about depression and anxiety as symptoms. Is your sense that these are related to the onset of a new chronic illness with profound life impact, or a separate medical symptom emerging after infection, or some combination?
I guess I would say that it's, from our results, it's partially due to the new onset of living with the new chronic conditions, and the uncertainty of living with this and what to expect. However, though, there is also discussion in the literature that this may be like a separate medical issue. So the jury's out. I don't have a accurate answer for you because the science isn't complete here. But it seems that it's from living with a new chronic conditions that are really uncertain.
Yeah, could I also add just, given the focus on racialized populations, I think one of the things that came up is that this is just part of it's exacerbating challenges they're already experiences within the region and structural inequalities that they were already experiencing. So I think there's part of that happening as well with this.
Mhm.
Okay, thank you. So people living with long COVID report experiencing slightly better healthcare management in later 2024 and 25. Has there been a follow-up to detect the current level of diagnosis compared to 2023?
Not that I'm aware of. I know there are some groups working with the PCC code right now that are expanding on what we did, but I don't know precisely what they're doing with it. So I suspect that will be coming in the not too distant future, an update to see how it's changing over time and how rates are changing and how the code use is changing in 2024, 25.
All right. And there's a question and maybe proposing why is it that more older females in Northern Ontario have long COVID?
To be honest, I have no idea. The Northern Ontario was kind of unexpected just because people are tend to be more remote, have less access to care there. Although potentially what could be happening is that people are waiting to go to the doctor, so symptoms worsen to a point, or they're not getting appropriate acute care, so they end up with long COVID. In terms of just women and older women in general are more likely to get long COVID. So that part is not exclusive to Northern Ontario, but I suspect the Northern Ontario part could be more related to the lack of acute care that then is meaning people aren't being properly treated, and then it's manifesting later on as long COVID potentially. But that's just a guess. I don't really have any data to suggest why any of that is the case.
And I'm going to ask a question. So I recognize that long COVID is an still ongoing thing. But looking ahead to potentially whatever the next emerging infection that might cause a pandemic would be, what would be your recommendations from your learnings to address any of the issues that you encountered with that you've seen with your projects? That's for either one of you.
Well, I guess I can take a stab at it. It's the need to establish clear definitions of disease. I mean, early on, I think, but I mean that's pretty objectively hard to do, and you can understand why it doesn't happen. But PCC is still really poorly defined. So just giving physicians a clear definition of what it is and what it isn't, I think would be helpful. Again, that's much easier said than done.
Yeah, I would just add that, in Peel region, what we've seen like in the first 100 interviews and then these 53 is just a general lack of trust among the populations with, and a lack of acknowledgement of their experiences. Certainly, there was a lot of upset around the vaccine rollout, where they were rolled out to and how they were rolled out. So, more community engaged, recognized approaches in responding to infectious diseases, but also managing them as needed. And that's what we're hoping in the next phase through our knowledge mobilization work, is that we can bring people to the table with those who are experiencing that, to look at developing interventions and supports that are culturally and racially appropriate.
Okay. Well, looking at the time, I think we're going to wrap this up. So I want to thank the three of you for taking your time to present your work today. If anybody attending has any additional questions, feel free to reach out to the panelists directly, or you can send an email to our inbox at ifp.dlsph@utoronto.ca. And I do want to highlight that, as I mentioned, this is an ongoing series, so our next session is going to be on November 11th. The topic on that one is more on impacts on individuals with disabilities, and we'll have Siobhan Niles from the Temerty Faculty of Medicine and Hillary Brown from University of Toronto Scarborough attending that one. Feel free to use the QR code to scan and register, or you can go to our websites, pandemics.utoronto.ca. to register, and you can also register for any of our subsequent ones from December through March. So once again, thank you all for attending today. Thank you for the presenters, and we will get the recording and slides out to everybody who's registered within about a week or so, and we look forward to seeing you at our November session. Thank you.
Thanks for the opportunity. Take care.
Thanks very much.